So you're busy administering vaccines now?
Yeah, we're one of the big vaccinators in Colorado. So we've done about, I think we're up over 25,000 doses, and we're one of the 25 health centers selected to get vaccine supplied directly from the government. So we're getting now, as of this week, we're getting 5,200 doses a week every week. Because part of the problem had been we wouldn't know until like Friday how much dose we were going to get for the next week, and we wouldn't know exactly until it actually showed up on Tuesday. So it's very hard to schedule in advance. We basically were scheduling our vaccine clinics literally a day or two in advance, but now we'll be able to schedule out as far as we need to. So it'll help.
Which vaccine are you distributing?
We get Moderna.
And so that's the one that has to stay at.
No, not as bad as Pfizer. Pfizer's the one that has to stay 100 below zero. Moderna is more like the freezer in your garage, kind of that temperature.
Okay.
Yeah.
But when you had little notice of when it was coming and how much you were getting, that means that the people who were hardest to reach, who most needed it, were the ones who were least likely to get it, right?
Absolutely. That has just been a struggle of all struggles. And we're putting a ton of time and effort into that. We thought initially, if we just send out a text blast to all of our patients, initially over the age of 75, then 70 and up, and then 65 and up, that we'd fill up our schedules. But, it's just amazing. What's amazing, Mark, is how well privileged white people like me and like you are able to negotiate the system. We're really good at it. So, we would put these notifications out to our patients, and we would have the clinics in our, the vaccine clinics in our clinics in low income areas where our clinics are. And initially we'd have 80% affluent white people show up from all over the Denver metro area.
Wow.
So we changed our approach quite a bit, and now we're up to more like 50% Latinx and other people of color, which is still below our population. Our population is about 70% Latinx in our patient population, but still we're getting better. But it is a lift, and we're still trying to figure out how to get to the population. It's a big lift. In fact, we had a meeting. I just left a meeting to talk to you, and some of the ideas that came up. One of the concerns was, well, that's going to take a lot of work. There's no way we're going to do this without a lot of work. The one thing we know for sure is if we just do what we've always done, by we I mean society. If we just do what we've always done, white people will continue to be advantaged over people of color. So it requires of us, and again, by that I mean society, a heavy lift, a heavy workload to fix that problem.
So what are some of the strategies you've employed?
Well, we are in a segregated society, right? We're not integrated. We're very segregated. So it turns out there are ways to get at different populations based on where you go. So we advertise in churches. If you go to Spanish-speaking Catholic churches, you're going to get a lot of Latinx folks. If you go to historically Black churches, you're going to get a lot of African Americans. So we're doing that. We're doing a lot of word of mouth. We tell, we get, Mrs. Hernandez to come in, and we tell her to tell all her friends. And we have community organizers on the ground, going to meetings and trying to get at the population that we want to serve. Then the additional problem, or the additional work that we have to engage in, is to try to gain trust of populations that have had very good reasons to not trust the medical establishment. So, that's just another part of it.
Yeah. Have you seen the videos that KHEC produced?
Yes, we have, you know, I sent those to our development and advocacy person, and I think she's using them in our public service announcements and other places. Yeah, but you know, one thing that we found is if we transmit out kind of broadly, the, the population that responds are, you know,
Right.
the affluent white people that know how to work the system.
Yeah. Well, Nancy and I got our first shots a couple of weeks ago, and it's Cook County, which is huge.
Yeah.
I mean,
Yeah.
you know, Weld County is still 4 times bigger in area. But and you know, we were signed up with probably 7 different systems, and even Lake County, which is next door to us, and so on. And it took her daughter, who made about 10 phone calls and finally found a site where we could get it. And we drove an hour to get there.
Yeah.
But we know people who've driven down to Champaign, Illinois.
Yeah.
From around.
What's that, like?
But again, you know, it's what we privileged people know how to do.
Right. And that's not a bad thing. It's good that we know how to do that. And everybody should know how to do that. The system should work so that people can engage with it. And, but you know, of course, as you know, the population we most want to serve and get to is also the population who has the best reasons to be extremely distrustful of the system.
Yeah.
I have a friend of mine that lives in Rochester, New York, who's an African-American guy, you know, grew up pretty low income, and he put a post on Facebook today. Let me see if I can find it, which speaks to this exactly. Something like, let me get this straight. After 400 years of, you know, not liking us because of our color, now you want us to get your shot? I'm not going to find it offhand, but it was, you know, it summed up pretty well the feeling among a lot of African Americans towards the system.
In the midst of this campaign, you're still doing everything else you do, right?
Yeah, it is very busy. I mean, our days start at 7 o'clock now every day, and we usually have our last meeting scheduled sometime after 5. So yeah, they're super long days. Yeah, because we're still trying to, you know, run a clinic and develop contracts with hospitals, and you know, keep our revenue going with productivity, and you know, recruit new doctors and develop new programs. I mean, all that other stuff is still happening. And I, you know, I think you get it. I'm in that place where I feel like there's no way I can do it all. So I just drop things, you know. There's just yesterday, I was thinking there's an email I needed to respond to that I got about 3 weeks ago, and I have to go try to find it. And then, you know, I couldn't find it. So somebody's, you know, saying bad things about me because I didn't respond to their email from 3 weeks ago. And I'm, you know, not, when new proposals come into me about things, I'm just letting them sit. You know, I just don't have time.
Yeah. So how big is your COVID load now? COVID patients?
You know, it's interesting now that we've gone so heavily into the vaccine effort, we're not testing anything like we used to do. We used to test, God, we probably tested 1,000 people a day. And now we're testing maybe, I don't even know if we're testing 100 people a day anymore. So I can't answer that question quite as well. I used to be able to tell you exactly what our percent positivity was, but you know, now I don't even know. Partly that's because there's so many places doing testing now, it's not as important for us to do it. So I think it's improved, although I will say that when I talk to my Latinx patients, I'm a little bit surprised when they tell me they have not had COVID, because such a large number of Latinx patients. Yeah, the estimate is that in the state, between 37 and 40% of Latinx patients or people have had COVID or have COVID. It's a super high percentage, and only something like 4% have been vaccinated. So, so yeah, it's been a very high COVID load among our patients.
And how about actively sick people with the disease?
Yeah. Yeah, that's been, that has been a problem for sure. I can only tell you that kind of anecdotally, just from my patients. I've had 2 or 3 patients in their late 30s and early 40s who have been intubated. None of them have died, but 2 of them have significant long haul COVID. One of them was in the hospital for 2 months and intubated for almost a month. And he got out of the hospital on December 31st, and his heart rate still goes to 150 if he just stands up out of his chair. He's oxygenating. He doesn't require supplemental oxygen, but his O2 sats drop to 88% if he does anything. So and then another guy is on chronic oxygen, and he's a long haul truck driver. So he goes up into the mountains where his O2 sats really drop. And the third one has that brain fog, that COVID can cause. So, so we're definitely seeing some significant morbidity, and that's just my patients. I'm only clinical 30% of the time. So our docs that are 100% clinical, I just assume that they have a significant caseload of folks with COVID sequelae.
How is your clinical staff holding up?
There's 2 answers to that. One is I am just astonished and really in awe every day of particularly our medical assistant staff. We hire these young women mostly, excuse me. We hire these young women, most of them are in their, most of them are barely 20 or in their 20s. And, they have a high school education plus their medical assistant degree. And then we load the entire operation of our system onto their shoulders. And it is amazing to me what they can do. We ask them to do more and more and more. When COVID hit, we disrupted their job description completely and gave them all sorts of extra duties. They really run the system. And I am just in awe of them every day. But there's burnout associated with that. And, although I never see it because they're always cheerful and pleasant and professional, as we run these COVID clinics. One thing about running COVID clinics where a lot of, affluent white people show up who have not heard about Salud, the compliments that we get about our MA staff is just incredible. But it is tough on them. The vast majority of them have young children. They're working long hours now, and it's difficult. Providers are also, we've been a year kind of now in this,
right,
in really kind of crisis mode, and providers are really wanting to get back. The way they say it is, we want to get back to the way things were. And I always tell them, we're never going back to the way things were. We're going back to some other thing. But they do want some sort of predictability in a system that works, where we're no longer changing things, every week. And I totally get that. So the burnout factor is definitely significant. The other thing, Mark, is that, we hire at Salud, we're pretty good at retaining docs. So we don't hire people. We're not on the 2-year, churn and burn cycle. Right. So we try to hire people for the long haul. And a lot of our docs, when we hired them, 5 to 10 years ago, our system was quite different then from where it's going to be a year or 2 from now. So, if you think about the 3 big areas where health takes place, in the hospital, in the clinics, and in the community, historically, primary care clinics have interacted closely with the hospital and not so much with the community, understanding that you have limited time, you can't do everything. And I think correctly, we're moving to an environment where we're going to be interacting more with the community and much less with the hospitals. You know, hospitals all have hospitalists now, and frankly, they don't need, it's not as important to them to have our doctors, you know, in their call rotations. But community is where you can really make an impact. That's more upstream, you know, and really get into some other efforts that make a difference in people's health. So, but we've hired a lot of doctors who, that isn't why they came to Salute. They came to Salute so they could practice full scope family medicine, including being in the hospital.
Right.
So as that's changing, and for financial reasons, frankly, well, it's not just financial, for financial reasons and overall health outcome reasons, we're sort of changing that. And so I'm finding that we're losing some docs around that also, docs that, you know, want to continue more in the traditional clinic hospital setting rather than clinic and community.
Say more about being more in the community. I understand the less in the hospital. You know, they went, as I'm sure you know, they went through that with Sunrise too in Fort Morgan, and had to renegotiate that with their doctors.
Yeah.
Because that's one reason why they went there, was that they could do this full service rural kind of practice.
Yeah.
Say more about how you've managed until now to retain your doctors, and how you envision you'll do it in the future with this new model. And I want to hear more about the new model. What does it mean doing in the community?
Yeah, so, you know, the way I think of it is historically, you know how primary care worked for most of my career and most of your career, right? Doctors would go to the hospital in the morning and see their patients, then go back to the clinic and see their outpatients, and field phone calls from the hospital during the day about their hospitalized patients. Oftentimes we go back to the hospital at night, and then we go home. And, you know, that model is part of what got us a 37th in the world in health outcomes. And as hospitals for their own financial reasons went to a hospitalist model, so they get shorter lengths of stay, they're being paid on a DRG basis. So the shorter the patients in the hospital, the more cost effective it is for the hospital. So they go to the hospitalist model so they can cut down. So now you have a patient who is often cared for by somebody they don't know. And they're being told, do this, do that, do the other thing. But it's not their doctor. They don't trust that doctor. And that's the argument for why, you know, that's an argument for why your own doctor should see you in the hospital, because you trust that person. But there's a cost to that, right? That makes for a tough day. If you have to go to the hospital first, then go to the clinic, then go back to the hospital, makes for a long day. If you try to add the hospital work to a provider's 8-hour day, then you lose productivity. And unfortunately, that's how we get paid, is on productivity. So you don't have a break-even model in that situation. So a few years ago, we started a program where we hired, actually we used AmeriCorps volunteers. So they're not volunteers, they're AmeriCorps members, they call them. So they're, you know, very smart, very passionate, very idealistic young people. And we trained them in this model where they would round in the hospital every day with the discharge planning team. They would round on Salute patients. They would get to know the patient in the hospital. They get to know the discharge plan. They would risk stratify the patient based on risk of readmission. And for the ones who were at high risk, who turned out to be about 2/3 of the patients, they would round on them at home after they got discharged. And make sure they understood the discharge plan, make sure they understood their medications correctly, make sure that everything was going the way it was supposed to, and then make sure they had a follow-up appointment with their PCP. That was the most incredible model, man. It cut our readmission rates in half, and it didn't require any doctor time. So it was really a great model. For reasons that we did not have control over, that program ended because the AmeriCorps funding got cut. But that would be an example of working in community. So now what we're looking at is hiring a cadre of community health workers or health promoters or whatever we want to call them, who will do that work from the community. So we can give people in the community a marketable skill at a living wage, train them in this model, And then they do that work, which we have shown to be effective in decreasing hospitalizations and improving health outcomes. But it's outside of the clinic walls. You know, it happens out in the community. So that would be one aspect of working in community. But others would be things like, which wouldn't even necessarily involve the doctors. It would be, you know, 65% of our patients have food insecurity. So what we should have are access to food so that I can write a prescription, you know, a week's worth of fresh vegetables or whatever, you know, whatever it is. And so basically it isn't so much that we're using our healthcare providers to work in the community. It's that we're converting the money that we used to spend and having them go to the hospital, because that's a big cost to us. Instead, we're using that money to do other things out in community. You know, here's another example, a doula program. You know, doulas have been shown to be highly effective. And particularly if you expand how doulas work, so they work with patients prenatally, do the labor coaching and labor support, and then also postnatally. And a lot of that work is in the home or out in community. But nobody pays for doulas. They're not on anybody's payer list, but they should be. So one of the programs that I would love to get funded somehow is a doula program. So we hire doulas, and again, it's hiring community folks, giving them a marketable skill at a living wage, and then they do that work, which will move us down the quadruple aim path. That will get us better health outcomes in terms of starting to decrease the excess morbidity and mortality among moms and babies of color at lower cost and with more satisfied patients and providers.
Would you now, you know, that's the direction in which we've known we've needed to go forever anyway.
Exactly.
And it's pretty clear that the crisis that's come with the pandemic has something to do with moving a little bit faster along that path. Would you, what do you think that mechanism has been? Why is it that the COVID crisis has moved primary care in the direction of the community?
I think for three reasons. One is it just tipped the model upside down, right? All of a sudden, all the cards have been thrown up in the air and we're trying to resort them as they fall. And some things we can resort that are required by the COVID pandemic, like telehealth. But because we're resorting all sorts of things, it also allows us to resort some other things that are sort of incidental, almost like, what do they call that? Unanticipated outcomes. That allowing us to do telehealth also allows us to do these other things. So that's one reason. The second reason is if we're really going to end the pandemic and try to make vaccine availability not yet just another place that exacerbates health disparities between the dominant culture and BIPOC populations. That means we have to do work in the community to get vaccines into the arms of the people that most need it. So just to get, you know, what we were talking about earlier, just the work that's involved in vaccinating the most at-risk populations, that requires us working out in community and doing things differently. The other thing is not necessarily related to COVID, but it happened contemporaneously with COVID. Well, actually, frankly, Mark, it's been happening for 419 years, but you know, it's really, you know, the whole George Floyd thing, which was, which was, you know, certainly not unique. It was just sort of the straw that I hope broke the damn camel's back. And all of a sudden, there seems to be finally some societal agreement that we need to fix this problem. I mean, it was so heartening to hear Joe Biden have that as one of his major things that he talked about in his, inauguration address. That societal racism we have got to fix. And I, you know, I've been talking about health disparities for years among various, in front of various audiences. And I always say, the thing that we should be losing sleep over every night is the unconscionable health disparity in in infant mortality among Black babies. And of course, maternal mortality also. It's just outrageous. And those are fixable problems. It's, you know, that's caused by the social determinants of health. They're not, you know, Black moms and babies don't have higher morbidity and mortality for some genetic reason. They have it because they don't have the same access to healthcare that they can trust. So, so now, for example, there's a birth bill a birth equity bill, I think it's called, in front of the Colorado State Legislature, which includes, for example, doula support. It would include reimbursement for doulas by Medicaid. So, so I think that's the third thing that's allowed us to get more out in community. You know, there's money, we're looking at money that's being made available both state and federally for community health worker programs. So we want to get our transitions of care program back. Just like, just, you know, the same population that knows how to negotiate the system to get their vaccines also knows how to negotiate the system from an inpatient hospitalization back to home and then back to clinic.
Right.
Although even among people that look like, I mean, we're doctors, so it's different for us, but even among the dominant white population, even there, it's problematic, right? I mean, it always amazes me there's not more avoidable rehospitalizations and more iatrogenic problems. You know, when your doctor tells you you should be taking Lasix every day, and then you have this bottle that says furosemide, you don't know what's what. So we can do a better job for everybody, but all of those obstacles and problems are exacerbated in the lower income,
yes,
more vulnerable populations.
Well, and frankly, healthcare has become unaffordable to the middle class. You know,
totally, it's ridiculous. It's
more than half of bankruptcies are now due to medical.
Yeah. You know, it kills me when you still hear complaints about Obamacare. The big complaint is that people lost the insurance they were happy with. They were only happy with that insurance because they never had to use it. If they ever did have to use it, they would be way unhappy with it because they always had super high deductibles. You know, they were essentially, in fact, we did a study on that in Colorado many years ago, looking at how do underinsured people with high deductibles, how do they use healthcare services? And what we found is that they, forwent, you know, they avoided recommended medical interventions, whether it was, you know, mostly for screening services, but also for buying medications and things like that, at the exact same rate as uninsured people, because they had a $10,000 or $5,000 deductible and they didn't have $5,000 to spend up to that, you know.
Yeah.
So so it's a terrible system, and I think those and we've known for a long time that excess mortality, 10% of that is due to access to healthcare services, and 90% is all those other things. And I think those three things that kind of blowing the healthcare system up, which allows us to put in all sorts of new things, and having to get out into the community to vaccinate the right population, and finally enough people's eyes opening to systemic racism is what's allowing us to get out into community.
How many sites are you administering vaccines at?
13.
13. And how many does Salute have altogether?
13.
Oh, so every site.
Every site, yeah.
Oh,
every site, every
what a
day.
logistical challenge.
It is. Our chief operations officer is amazing. She's extremely detail oriented. She's an extremely hard worker. I think she came to Salute. She came to Salute as a very experienced COO down in Colorado Springs. And I think she was hoping she could slow down a little bit before she retired. But holy smokes, have we just dumped the work on her. She's just been amazing. And it's really, I think of it as like being a general and mobilizing, you know, 1 million troops, because she has she just has an amazing logistical challenge in front of her every day.
You must even have a motor pool for carting the vaccine around. I assume they don't deliver it to all 13 sites, do they?
Yeah, they deliver it to all 13 sites.
Oh.
So we get, we get vaccine delivered to every site, and we have all the, we have all the cold containers. We even bought those 100 below refrigerators. So if we do get Pfizer, we'll be set. So we get, every site gets vaccine every day. Well, every week. Yeah, it is a challenge. But now that we have a stable supply of vaccine every week, because it used to vary, we didn't know, some weeks we'd get 2,000 doses, some weeks we'd get 800 doses. It was just all over the place. But now we'll get 5,200 doses every week.
Mm-hmm. And I wonder how they came out with that exact number.
Don't know.
52 is 13 times 4.
There you
for
go.
Example.
But it's not, but we're not getting 400 doses per site.
I hope not.
Yeah, but there's some nonsense there. I don't mean nonsense. There's some, glitches in the system. One of our small sites is our women's center, and that got 1,200 doses this week. And one of our moderate size sites is Fort Lupton, and we got 0 doses. So we'll be moving it around within our system to make sure it goes where it needs to go. But even that adds to the logistical challenge.
Have you had to waste any doses?
No. We'll do, for example, I was doing a vaccine clinic a couple of weeks ago, and we ended up with, in fact, we vaccinated the governor. So the governor asked us if he could be vaccinated by us. We said, sure. He said, I'm going to bring 4 people down. But the other 3 people he was going to bring decided not to show up. So it was just him. So we had 3 extra doses. So, I called a friend of mine who's a teacher, and he rushed in, and then we found 2 people in the waiting room. So, we'll go out in the street if we have to and pull people. Yeah, we have not wasted a single dose.
Yeah, a sandwich board.
Yeah, exactly. Yeah. Our wait list for vaccines is 25,000 now, 23,000 now.
Mm-hmm. So that's still 5 weeks of deliveries.
Yeah, although I think a lot of those folks probably, like you did, signed up in multiple different institutions and probably have been vaccinated. So we're going to resend a note out to all 23,000 and tell them to respond if they still want the vaccine, and try to clean that list up.
What else? I feel, but that's personally just because I got vaccinated, and after I get my second one, I'm going to wait a little bit longer and drive to see my children and grandchildren who I haven't seen in over a year.
Wow.
So I feel, and the sun's shining today in Chicago, which is really nice. But I feel, a bit of a light at the end of the tunnel. I mean, also with the election and so on.
Yeah.
I assume you're there too. You feel like this isn't just going to go on forever. And
yeah, absolutely. I feel that way. I feel like, I think we might've talked about this last time, early in the pandemic, a year ago, there was this ominous feeling, we were working 7 days a week trying to figure things out. And it just felt ominous, but now it's really exciting. It's, we feel like we're going to slowly pull out of this thing. And the key, again, as you know, is getting enough people vaccinated so there's not this reservoir of mutating virus out there that's going to keep creating new variants. But even if that happens, frankly, these mRNA things are so genius that they can make a new vaccine within weeks. And I was just reading an article in the New York Times, I think it was yesterday, that they're not, because the new vaccines will essentially be the same. They'll be like the new flu vaccine,
right?
That it won't need to be tested again, so that when they make a new vaccine against a variant, it'll just. So what I'm betting is that every year we're going to have to get a COVID vaccine, and it's going to end up being a number of different little mRNA strands to cover the new variants that they've uncovered in the past year, because we will still have, just like the flu virus, you know, reservoirs in birds, the COVID virus is going to reservoir in humans, that, you know, populations that haven't been well vaccinated, you know, probably in Boulder and in developing countries.
So in two different people's republics.
Exactly. That's
Congo
right.
and Boulder.
Right. Exactly.
Yeah. I'm with you, and not only that, I mean, flu is remarkable in how rapidly it produces infectious variants.
Yeah.
I'd be surprised if COVID. I'd be surprised if we need an annual. I mean, maybe that's just wishful thinking.
I hope you're right. That would be
booster.
Yeah.
But so far, you know, we just don't know.
Yeah, and I really hope you're right. I mean, from everything I've read, it sounds like it mutates much more slowly than the flu viruses. And it may be that the variants don't matter. It may be that if you're vaccinated, the variant is more likely to cause mild illness, and we don't care about mild illness, right? So, yeah. So yeah, I hope you're right. That would be fantastic, because I am really looking forward to getting back to, I don't ever want to go back to the way the healthcare system was, but I definitely want to go back to not having to wear a mask everywhere.
Yeah. Let me ask you about, so we've talked about like how your staff is holding up, how the providers are holding up. How about patients? What do you hear from them? How are the population you encounter? How do you think they're doing?
You know, there's a lot more anxiety out there. Our behavioral health providers are very busy. I think that some patients have managed it better than others, but, you know, I found in our Latinx population, because they've had such a burden of disease, there's a ton of anxiety in that population. I think most patients are getting used to this telehealth thing. And as we tweak it and work the bugs out so that, you know, we're better at identifying which visits will be good for telehealth and which visits should just be scheduled right in clinic. As we work the bugs out of that, it's going to become better and better. I think patients will be more and more satisfied. But even as it is, the majority of our patients really like the opportunity for a telehealth visit.
Yeah. And you include phone contact in that.
Yeah.
Doesn't just mean interactive video with people who have a computer who can.
Exactly. It's I would say 90% of our telehealth visits are phone only.
Yeah.
The video, I think it's going to change over time. I think, you know, right now there's people down in their basements figuring out better ways for us to conduct telehealth visits, and and new applications for that. You know, right now our televideo is really sketchy. Like yesterday, I had 2 televideo. I think I had 11 patients total, and 2 of them were televideo. And I would say I'm about 50% successful on my televideo. It either doesn't work, or it's a bad connection, or I can't see what I'm supposed to see.
Yeah.
But as that gets better, yeah, then I think we'll have more access. But it works fine with telehealth. You know, it's one of my televideo visits yesterday was a little girl had a paronychia, so it was very helpful to be able to see that. And then I just had her come into the clinic, and I went in and took care of it. But most things I don't really need to see, right? Most of what we do is cognitive.
That's right. And which is, you know, I've been talking and writing and studying about telehealth for a long time, before it was cool. And, you know, one of the main points I've always made is the telephone is telehealth.
Absolutely.
The answer isn't get a fancy system. Now what's the problem?
That's exactly right, Mark. And that, you know, that has been really tough for people to understand, but you're totally right. When people talk about early on, I think now people have it figured out, but early on, in this pandemic. When people talk about telehealth, I'd say, well, what's your definition of telehealth? We do telehealth we've always done telehealth, right? We just don't get paid for it. We call patients with results of their studies, or we ask them how they're doing on this, that, or the other thing. We just didn't get paid for it.
Right.
But you don't have to have, you don't have to have a Dick Tracy phone to do telehealth.
That's right. Which is really amazing because we really do have those now.
That's right. Yeah.
And his was a wrist radio, wasn't it?
That's right.
You know, that was unimaginably high tech.
Right. Yeah.
Back then. I had one more question I wanted to ask. Oh no, I was going to share an observation with you, because I've done a lot of these, and some of them are like this are re-interviews. Oh, by the way, today's February 24th, 2021, and I'm talking to Tillman Farley, Medical Director of Salud Family Health Center. And if you don't remember that, just read his hat.
That's right.
Yeah, that has to be in somewhere. You know, that's like a word from the sponsor.
Sure.
So when I first was interviewing people, which was starting out last March, and people were pretty overwhelmed, but it was like, we're all in this fight and we're going to figure this out and we're going to do it. And we're working long hours and we're doing what we can to keep up everybody's morale. And, you know, and then beginning a few months ago, people were just saying, oh, we're so tired. We're just, we're having trouble just keeping going and keeping staff and so on. And now we're in a third phase.
That's good.
In the response to this. And I think you're a great example of that, of saying, no, it's a new world and we're figuring this out and we're moving into it.
Yeah, that's interesting to hear that trajectory, because that definitely mirrors our situation and my situation. And we even, for most of the past year, early on in this thing, we suspended everybody's vacation. We said no vacation because we don't know who we're going to be losing to illness. And we've only recently put that back. But but yeah, that definitely contributed to burnout. But yeah, there's more people are much more energized now. And I actually scheduled a vacation for myself in September. So I'm confident enough to have bought a plane ticket and made reservations. And, you know, I'm going to Croatia in September.
Croatia. I understand why. I understand it's very beautiful.
It really is pretty. My wife and I like to sail, and you can rent sailboats and sail on the Adriatic Sea there. It's pretty gorgeous.
Oh, lovely. Cool.
Yeah.
All right. So anything else? Any other comments or anything?
No, I think you covered everything, Mark. I think I think just to emphasize a point that we started with is, you know, in order to make sure that vaccine availability doesn't just enhance already existing health disparities, is going to require work. And if we don't, if as a society, we don't accept that work, if we just say we're going to do mass vaccination clinics to whoever shows up, we will exacerbate already bad disparities.
I do believe, and as a writer, I've seen it as my mission. Consciousness is changing, and without that, well, I mean, but that's who knows when it's, you know, there are tipping points. I mean, I've predicted 6 of the last 0 collapses of the healthcare system. You know, when I started medical school, it was 7% of the GNP, and now it's north of 18%. We keep saying, well, it can't go on like this.
Yeah.
And it does. So, but in the meantime, I do feel that awareness, that consciousness is shifting, and it's shifting in the population.
Yeah, I think you're right about that. Yeah.
And probably ahead of the politicians.
Yeah, probably so.
Although dig this, I just heard that Ken Buck is going to do work at volunteer at a vaccine clinic at Sunrise.
Oh, really?
Now, I sincerely hope it's not just a press event.
Yeah.
That it's something more than a PR thing. But still,
Yeah, that's impressive. Wow, good. That's great. That's fantastic.
Yeah.
Yeah.
Well, I don't know if you know this either, but Monica Micah, who you probably know, who's been director of KX for the last 7 years.
Yeah.
And done just she's the one who set this whole project in motion. Done such a wonderful job. She's his district representative.
Ken Bucks?
No. She left
Ken
Ken
Bucks?
And works for Ken Buck.
Oh my gosh! Wow.
No, but I think she's the one who's getting him to go to Sunrise. So.
Good for her. That's great. That's fantastic.
So,
any movement towards the center by Ken Buck would be great.
Yes.